So hi everyone, today we are delighted to have Dr. Eve Crane, who is my colleague and really a star in the world of hematopathology, to talk to us about just general hematopathology cases and to show us some cases of hematopathology cases that occurred in the mediastinum. We're going to have a kind of a chat format as before with my colleague Matt Cecchini. Dr. Crane is actually very, very well accomplished and has a CV that's so large that I can't even touch on it. But I'm going to say to be brief that she's very, very well published, has interest in EBV-related lymphomas, and has worked at various, world-renowned institutions before coming to us, and is now my colleague at the Cleveland Clinic. So, Eve, please take it away.
Okay, well, I'm very honored to be here on one of these first episodes here of the lung path guys, or yeah. how do we call it, the car talk guys of the lung. There are a lot of cases that kind of overlap between maybe reactive conditions and lymphomas within the mediastinum, and they can be very challenging and kind of go back and forth. Today we're going to present a few classic cases. The first one I think can particularly raise the challenge of whether or not it's a reactive condition or a lymphoma, and was a case that was actually shared between our departments previously. I think this is a good place to start. But yeah, you guys are more accomplished than me. I'm a little bit intimidated to be showing up on this show, but thank you for the very kind introduction, Sanjay. All right. Looking forward to it. So this is actually our first case here, and you can see at low power, we do have a fairly dense lymphoid infiltrate. This was in the mediastinum, and the question is always kind of what is the tissue? Did we just get a lymph node out of there? Because they often just say mediastinal mass, and you're not exactly sure what they retrieved during the actual biopsy. And so we tend to want to look a little bit closer and see if we can get any hints of exactly what the tissue might be. And of course, the differential would also include the thymus in there. And so you'd want to see, is there any evidence of a thymic epithelium? And sometimes you can usually see it, obviously morphologically, but sometimes we also like to do a stain just to make sure kind of how it looks and what we're dealing with. So I don't know if Sanjay wanted to comment on anything we're looking at or a place we might want to.
Yeah, I agree with that. We've talked about this before, finding thymic tissue in, atrophic thymic tissue at the edge of a thymoma and so forth, and cytokeratin. And I brought up, a couple of episodes back, I brought up the thing that one of my nightmares is to have thymic tissue in a lymphoma, so there's cytokeratin in the background, and you think, oh, so this is cytokeratin and lymphoid tissue, so it's a thymoma. And thankfully that's not very common, at least in my experience, but sometimes it does happen. Sometimes you will get a bona fide lymphoma and then thymic tissue at the edge of it. So you really have to be able to tell what's normal or not. So I agree with you. I mean, sometimes just a pancytokeratin stain is enough to pick up those little bits of thymic epithelium.
Which I think, we don't have that scanned in, but I think on this particular tissue, we do have it. Let me see if I can get that for you to see kind of, it depends on how much epithelium that you have. Let's see here. Here we go.
Yep.
Yeah. So this is just an AE1, AE3, which is my favorite cytokeratin to use in the lymphoma world. It tends to not show a lot of background staining with lymphoid elements and fairly good. I don't know what's your favorite. You guys probably have more favorite cytokeratins than I do, but.
No, mine is the pankeratin too.
Just the pankeratin. All right.
I just hate the other more, sort of specific keratins, because the main issue really in my world is it carcinoma or not?
Yeah.
Or where is the epithelium? And for that, a pankeratin is enough. So I don't know, Matt, what do you think about that?
I use a pankeratin too, and ours is actually a cocktail of A1, A3, and CAM. So I find that covers most things, and I use that as my broad screening marker mostly.
Oh, that's nice. Yeah.
And so that's a little bit of the thymic epithelium left there with that keratin it's highlighting.
Yeah, so we can see, maybe the epithelium is a little bit expanded here by some of the lymphoid cells.
Yeah. And this would also show up on the TDT stain, right? So the residual thymic tissue should show up on the TDT as well.
I hope we did. I was just watching your first episode where you spoke to the virtues of doing a TDT stain, but did we actually do it?
Yeah, might not have done it in this case. Maybe
we might not have done it in this case. Yeah, I think because there was just so much of the kind of the follicular and kind of the mature lymphoid infiltrate. And that we did have the nice evidence of the thymic epithelium there, that they're fairly sure it was thymus. And I guess the differential in this case, going back to our H&E, we didn't see a lot of the immature cells that you would typically see in a kind of a thing where you're looking more like, could this be a lymphoblastic lymphoma or residual thymus? Because you can, there's so many pitfalls in the mediastinum, both between low grade as well as like high grade or kind of more immature cells. It's kind of bizarre how you can have such a range of mimickers.
Can I make an observation here, Eve? Like, I think you just went past like a really prominent lymphoid follicle. So I think, one thing that happened here was that because of these prominent lymphoid follicles, and the patient also had a history of Sjogren's syndrome, that there was, my thought was, why is this not just reactive lymphoid hyperplasia in the thymus? Which is so common in our world where we see myasthenia gravis resections. That's the most common finding in our world, to see thymic follicular hyperplasia. And the one thing that bothered me about this case was that the lymphoid infiltrates seem to be going into the fat. So can you address that, Eve? Is that like a reliable finding to tell a lymphoma from a reactive thing, or no?
It's helpful, but it's certainly not 100%. You can certainly have some of the reactive processes also may extend into the fat, but it's certainly another thing that kind of makes you more concerned that you're dealing with a lymphoma. But these low-grade lymphomas, I mean, that's why we really love having flow cytometry, because we really want to know, is there a clonal population there, like a bona fide, true clonal population? Because you can have the extensive plasmacytic differentiation with all of these chronic inflammatory conditions as well. And sure, it'll be polytypic, but the plasma cells in the setting of a marginal zone lymphoma may also be polytypic. So you really haven't gotten anywhere. So these can be definitely challenging. And in the setting of kind of the Sjogren's patients are at increased risk. They have, of patients with autoimmune disease, they have the highest risk of developing a MALT-type lymphoma, often involving the salivary gland, but it may be anywhere. But the risk is quite high. So they may have these reactive conditions, and there may be some sort of gray area. I feel like there is a gray area between something that's becoming sort of towards a lymphoma versus something that's reactive. And so these are always challenging.
Yeah,
of course, it's
good that you brought that up. Can I say, Eve, like that was actually going to be one of my questions down the line. I find actually marginal zone to be, at least the subtle forms of it, to be the hardest to tell from reactive conditions. I don't know if others do too, but for me, that's where a hempath consult is absolutely essential, because I can't be sure. In the lung case, there's the additional benefit of seeing a lymphangitic distribution, which doesn't happen with reactive things. So I'm I'm much more confident when it comes to the lung. But when it comes to the mediastinum, now to tell a follicular versus hyperplasia versus lymphoma, I find that it hinges on that thing of clonality and so can you explain why you use the term clonality in one sentence and then you switch to polytypic in another? Does that mean different things, and how do you, like, when do you use clonal and when do you use monotypic and polytypic?
Yeah, I mean, I think clonal is another kind of challenge that we have as well, because, for example, you can measure clonality by flow cytometry to look at individual cells. Like, do they each have the same? Are they all kappa restricted? Are they all lambda restricted? But you can also look, which is often that we do in these cases because maybe you didn't have flow cytometry, that you would look just by molecular techniques and see if you find a dominant rearrangement of IgH or Ig kappa in there. And you can definitely find a clonal rearrangement also in a reactive process, particularly, you may not see a clonal population by flow, but you may be able to detect a clone by molecular studies. So you can't, particularly, you can't necessarily hang your hat on finding the clone as well. And the clone may be restricted to the B cell population and not be, there may be associated plasma cells that may not be clonally restricted. So when we look by our staining methods, and I'm going to show you another cool staining method that we just got, which is very helpful in this setting, because typically you have plasma cells will accumulate that light chain in their cytoplasm, so we can see them by our immunohistochemical stains. But the B cells have that receptor on their surface, so we can see it by flow, but we really can't see it by IHC. And so, yeah, so you're kind of stuck as well, is this really clonal? Well, I detected a clone by molecular, but maybe that could be a reactive clone. And so then you're down to looking again at the morphology, which is of course what we should be doing anyway, but I do like to do stains to be sure.
Yeah.
So I don't know, that wasn't really a good one sentence answer.
So, but can I ask you, so to the non-expert like me, Eve, it sounds like you're saying that clonality will not always give you a straightforward answer.
It's
right?
not always straightforward. So the
what
other
is
thing,
the gold standard then? Is it morphology? Is that the final gold
I
standard?
guess the gold standard is morphology. The other thing that you'll see us do all the time is get a 3 and a 20. So in a reactive situation, you're going to see a lot of follicles, and in a marginal zone, you're going to see a lot of follicles. So if we go back to where we were here, particularly in this area, you want to see the nice reactive follicles in a marginal zone, but kind of your ratio to how many cells you have outside of the follicles, whether they're 3 or 20, and kind of how these follicles look. And some of these follicles are a little bit small, they're a little bit maybe run over, and we're seeing an expanded marginal zone on these guys.
Can you show us the expanded marginal zone? Like, where do you look for that in a?
So we like to talk about, and so you kind of have these cells on the outside of the follicle here, which have a little bit more clear cytoplasm. We sometimes like to call them monocytoid like cells, but these kind of marginal zone cells that are cells that have in a normal germinal center undergone the germinal center reaction. They crawl out there, they're kind of differentiating towards plasma cells, and that they're becoming ready to secrete their immunoglobulin. And so you're going to see an increase in these kind of post-germinal center marginal zone cells, potentially in a reactive condition as well, or like in the spleen, you're going to see a lot of those increased marginal zone cells. But also in a marginal zone lymphoma, you see these cells that are kind of these post-germinal center B cells that are starting to get more cytoplasm, some maybe kind of more plasmacytoid in appearance, and then some go all the way to being a plasma cell.
I see. Can I ask you another dumb question, Eve? The dumb question is the cell a marginal zone cell because it is in the marginal zone? Or is the marginal zone called the marginal zone because it has marginal zone cell? Like, which way is it defined?
I guess we'd have to go back to like the early, these are not easy questions. We have to go back to like the early days of pathology to see why they did that. But I think it was probably the marginal zone was called that. They probably defined morphologically what they saw, the follicles they saw, the germinal center, the mantle zone, the marginal zone.
I see.
And
so it's not true that any cell in the outside of the mantle zone is a marginal zone cell, right? It has to be a certain kind of cell.
It has to be a certain kind, because you always have a mixture of cell types out there. Like there's specialized histiocytes that are out there. There's specialized dendritic cells that are in different areas. So yeah, to be a marginal zone B cell, you have to have that B cell phenotype, and then they have a specific surface markers. So you could also identify them by flow cytometry if you did sort of sophisticated methods to look at kind of how they looked. Yeah, so they do have a specific phenotype, and then they tend to have this also morphology that's kind of more of a monocytoid look, particularly in a marginal zone lymphoma, or particularly well developed in the normal spleen. You see the marginal zone really nicely in the normal spleen, but in a reactive, which ideally I would have brought in a reactive inflammatory infiltrate that may not be as developed. Yeah. But the other cheat that we do routinely is to look at kind of the ratio of CD3 to CD20. Because in a reactive infiltrate, you're going to see those germinal centers and maybe they have some marginal zone, but typically you're going to have more CD3 positive T cells than you are of the CD20 positive B cells. And so anytime we start seeing a big expanse, because this is why I got a little nervous, because you said you scanned the slides, which I was like, great. But then I was like, oh no, where's the stains? Because I wouldn't feel comfortable saying that this was lymphoma,
right?
Just on this. I mean, I think you could definitely favor it, particularly like look at this guy. There's all this expanded of these small B cells out here. It definitely looks worrisome. And this guy, this guy isn't even really that. He's just a small germinal center. And you've got all this expanded. Like these are some really nice monocytoid guys out there. But I just want to be double sure those guys are B cells. Like that's really, because you can see various kind of small lymphoid expansions in the paracortex as well, or even like an angioimmunoblastic lymphoma is a T cell lymphoma, and they're not always, at the early stages in particular, you see this kind of paracortical expansion of monocytoid cells, as well as kind of variable germinal centers and plasma cells and things. And it can be dangerous. It could potentially mimic a marginal zone, and you definitely would not want to mix those two up, like completely different things going on. So yeah, just want to make double sure what you've got. And let me see if I can show you the CD3 versus CD20 on this particular case. Maybe. This is a CD3, which is like, well, there are a lot of CD3 in there, to be honest, which is why, well, we never get one stain. So there's one of our little germinal centers there, and you can see kind of a targetoid appearance around it.
Now, is it possible, Eve, that some of the process is a reactive hyperplasia and the malt is only part of the mass, or does it always completely replace the underlying?
Yeah, no, I mean, I think it's probably, like follicular lymphoma, we definitely have a well-defined entity now, the in situ follicular neoplasia, because we can see where it's, because we got that bright BCL2 that shows up in that entity within the germinal center. And you can like, oh, well, it's like just these two follicles here. But I think with marginal zone being so difficult to define, because you do have those reactive germinal centers mixed in. Yeah, no, that's a good point, that it probably does in some cases, but it's not as easy to identify, and maybe the part that you sent for flow wasn't as much involved as the part that you're looking at, or one or the other. So yeah, I think there definitely could be, but that's a tough one.
So are you saying this case is a tough one? Like it's not an obvious marginal?
I think this is a nice one.
Okay.
I think this is a nice case, but I didn't sign out this case. But yeah, I mean, the top line was still a little bit, favor that, so I think it's always a little bit tough. I think particularly when you didn't have the flow to go with it, and a person who has an autoimmune disease as well that may have a potential to have a lot of reactive follicles. So
can you show us at low mag what this 20 looks like, Eve? So what is so we can get some idea of
let's see.
Oh, it's just diffusely.
It's diffusely. So that's the 20, and then going back again to the 3. They always add up to more than 100%. I don't know, but the 20 is always a lot. Yeah. So, but this, in this case, you can see like, wow, that's, really got sheets of 20. This is really concerning. Once you have that, you're like, that really looks like it's probably a lymphoma.
Yeah. Well, that's a great point to make for trainees, isn't it? I mean, just a simple 3 and 20 is one of your biggest tools, most easily interpretable tools, especially in the lung. I find, like, if you have a CD20 heavy process, that's probably not reactive.
Agreed.
It's probably not. Right? And then here's the other thing you think would be really good. You think your kappa lambda is going to be really good. It's like, all right, I'll just get a kappa lambda. This will be a slam dunk. This is the kappa, and sometimes it is. It's definitely always good to get it.
Yeah.
That's the kappa, and this is the lambda. And kind of the way that recombination works, that you're always going to have more kappa than lambda, or you should have more kappa than lambda. So it's like, well, I got more kappa than lambda, but oh, it's like more, but maybe it. And then sometimes people count them, which you can do.
Yeah.
But it's not as good as you'd like. You're like, oh, that's kind of.
I always found this the most challenging thing in heme path was the kappa lambda, and like I was staring back and forth and just scratching my head, like I don't know, are they the same? And
Are they the same? And then you're like, well, then it doesn't matter if they are, I guess. Or like, I still would really like to know this thing is clonal. Yeah, so this one, the molecular studies weren't done, but we do have a new stain that uses ultra-sensitive, that's not the right one. Let's see, that uses ultra-sensitive ISH for kappa and lambda, because the B cells are making, they have mRNA for the kappa or lambda chain that they're making. So you could look at it, and it's also kind of nice to see kappa and lambda together.
Yeah, it's really nice.
So
and
what's
so
the red and brown here, Eve? So can you break it down for us? What's the red and what's the brown? And
So these are the brown is our usual DAB, and that's staining the kappa. That's using, but it's an ISH probe for kappa. So it's looking actually at the RNA here rather than the protein kappa product, which is what we were looking at before. And then the red, which is used a lot, for example, in the derm path, is a chromogen that's used here for lambda. And so this is a low power image. So at low power, we can see again that the plasma cells are kind of jumping out. They're the easiest to see. And there is a mixture of kappa and lambda, but that we probably do have a little bit more of the kappa. But if we go, let's see if it'll work. If we go at higher power, we can see now that a lot of those little lymphocytes, which we knew were B cells, are also staining, some brown and some red. And it's like, uh-oh. So they look sort of mixed. They look
so
sort
can
of
you
mixed
clearly
there.
tell what's plasma cell and lymphocyte on this, Eve? Because I can't, like from morphologically, I can't.
Oh yeah.
You can. Yeah.
Well, so the ones that are the darker staining ones, those are the plasma cells, the ones that are the larger cells. So the ones that are very fine, where we're not seeing stuff very well. This stain we actually made it. I don't know if you can order it because I thought it's still confusing. It's still kind of getting rolling. But okay, so this area here is kind of interesting. So this here we can see is probably a residual germinal center here. And then we've got plasma cells outside that are polytypic, maybe a little kappa predominant, things going on in this germinal center, kind of mixed. And here it's a little bit challenging, but I think there you can see that there is some lambda for sure, that's pink, and then some kappa. But then we have these areas potentially in a marginal zone like distribution, or kind of expanded here, that were our B cells that are more brown, that are more kappa restricted.
I see.
And so that helps. So maybe it's like, this is why I cry when people don't send flow cytometry. But anyway, but you can still, I think you can still appreciate that. And maybe if we go a little bit higher power, believe me, I don't think you guys look convinced. You look worried.
No, we do appreciate it, and we appreciate it in the sense that we appreciate that there are hematopathologists who look at this stuff because it's difficult, you know.
I think it's difficult. Yeah. And the marginal zone is probably the most difficult too, I think, because, well, and it's also, it's not like you told somebody they have Burkitt or something, because some of the marginal zones, they may take a while to evolve. There's some of them that, for example, with H. pylori, okay, there's a clone there. It does look like it's evolving into a marginal zone, but, just go ahead and treat the H. pylori, kind of thing. So, I mean, it's not as much of a night and day diagnosis either sometimes in terms of therapy, or you can wait and see, what sort of therapy they would need. But yeah, it's a little challenging, but I think it's kind of interesting because in these specimens where we don't have flow and you don't really have definite clonal restricted by plasma cells, it gives you another chance in addition to the molecular studies to kind of see morphologically where that clonal population is. So it's kind of cool. Like these, we do see a relative, and I think the lambda is a little bit easier to see because of the red, but you know, in this area you can see, okay, there are some mixtures here. There's some mixtures in the residual germinal center, but these areas of expanded small b's are mostly kappa.
Cool.
But yeah, that's tough. I think the other one that people like to use, which is more familiar, maybe I'm gonna go something less scary here, is the CD43.
Yeah, I was gonna ask you about that as like a marker of a neoplastic proliferation. Does it make sense? I mean, do you guys use it? Is it reliable?
I probably don't use it as much as I could. Yeah, so it's tough because you do have to compare, you know, definitely with the 3, because normal T cells are going to express CD43. Other things are going to express CD43 like plasma cells and histiocytes. And so you're going to have to be sure, are those really, you know, and I think I can see here maybe like a 2-tone look to it, that maybe I have some darker guys and some lymphoid cells that are maybe a little bit lighter. And this is the CD3. So I think we definitely have more. But like I say, you might have more because of the histiocytes and plasma cells and other things. So it's a little bit, sometimes it's very clear. And I think particularly in like a gastric malt, it's very helpful because then you're like, okay, because usually you have way more 20 than 3. They're mostly lymphocytes. And then the 43 lights up, you're like, yeah, that, you know, that looks like it's a malt. This one I think is a little more challenging, but I do think there is at least partial expression. But yeah, CD43 you'll see on other small B cell lymphomas like CLL. It's on those guys as well. So yeah, I think it is definitely helpful in this setting, and maybe more widespread availability and kind of comfort level with that.
Yeah.
I think so. That's a nice one. My other favorite one to get is the CD21, which, you know, because sometimes you don't see the residual germinal centers in there. Maybe you have a malt lymphoma that's almost all plasma cells or something. And you're like, is this really a malt, or am I dealing with a plasmacytoma, or what's going on? And so, or, you know, sometimes you have kind of an overrunning of the paracortex by something else, and you have really tiny germinal centers, very tightly, you know, very tight, small dendritic meshworks. But usually in a marginal zone, you're going to see, let's see if this will work, increased, kind of slightly expanded or disrupted meshworks. And yeah, so that's nice. So that kind of, it's not specific, but that kind of adds to it. Of course, if you had like expanded reactive germinal centers, you may see kind of larger germinal, larger meshworks with that too. So it's like, yeah, it's not perfect, but it kind of helps differentiate if something else is overrunning the paracortex, like a T cell lymphoma, or I have seen TALL like diffusely, you know, increasing the paracortex, leaving some intact germinal centers. Like then you're going to see these little, you know, more small dendritic meshworks.
Yeah, I think it's helpful just for trainees just to know that you can have just reactive looking germinal centers in a whole, you know, in lymphomas of various kinds, whether they are part of the tumor or overridden by the tumor. But just because you have an occasional reactive looking lymphoid follicle doesn't mean the whole thing is benign, right, Eve?
Yeah, no, I find that really helpful to kind of look at, and the other thing that comes into that is like KI67, to kind of say, hey, you know, are there reactive germinal centers in here? Because that'll kind of pick them up easily, and kind of the ratio of how they look compared to the other. And yeah, here you can see, oh, look, those little, you know, little germinal centers in here, these little guys, maybe this guy's a little bit broken up, and there's just kind of expansive stuff that has a pretty low proliferation rate. And so, yeah, if you're looking at more of a like a true follicular hyperplasia or something like that, you may see, you know, kind of larger germinal centers throughout, rather than these just like little small, well, yeah, and they can be variably interspersed, but these guys are well polarized. They're normal germinal centers, but they're just kind of being partially infiltrated and surrounded by this marginal zone lymphoma. So yeah, so you can't just, and they won't have BCL2, of course. They're normal germinal centers.
So the germinal centers in marginal zone lymphomas in general, are they considered part of the tumor, or is it residual germinal centers from what was previously a lymph node?
Yeah, there are residual germinal centers in the lymph node. I guess I'm not exactly, I probably shouldn't even talk about this to confuse anyone. But like, for example, you start getting a marginal zone lymphoma, like in the bone marrow or something, you'll also see germinal centers in there. So something about, I don't know if they're in part induced by the tumor or, you know, but they do have they're polytypic. The germinal center components themselves are normal germinal centers, but they may, you know, and then the malt lymphoma is, you know, a place where you don't normally have lymphoid tissue. It's lymphoid tissue that's induced. So I guess they wouldn't necessarily be like in a lymph node, if you're a nodal marginal zone lymphoma, those are probably the follicles that were already there. But in a malt lymphoma, like in the stomach or something, you don't normally have a whole bunch of germinal centers in there, but somehow they're induced by the inflammation. And then, you know, then you have, you know, potentially as a secondary event, getting that lymphoma on top of that induced inflammation. So I guess they're normal, but they shouldn't necessarily be there.
Mm-hmm. Mm-hmm.
And things like the tonsil, like you don't really get marginal zone of the, you know, involving like a tonsil or something like that, where you have a normal, basically germinal centers and normal development of inflammatory process there. So it's kind of, I think there's a lot more to learn about malt lymphomas.
Yeah, no, this is great. We've touched on a lot of different things. So should we switch over to the next one now?
Sure. Yeah, I can show a couple of other things, for example, that we touched on today. All right. Nice. Yeah. All right. So this is another, this is a cervical node here. And in this case, we're not seeing as much in the way of, like, here's some germinal centers over here, some kind of residual germinal centers over here. And we see this
effaced, isn't it? I mean, the effaced.
Yeah, this thing doesn't look good. It's like, just you can see from the low power, it's like, wow, that's it's really blue. That's really effaced. And that's kind of basically a good way to do your differential. Like this is something, you know, maybe it's a small round blue cell tumor. We go closer to these guys and they're very monotonous. We don't see a lot of residual architecture that's left anywhere. They don't have any cytoplasm. They're immature looking. I think it's hard to tell from just like an H&E section necessarily sometimes, you know, is this like a blastic cell, or, you know, you'd hate to, especially if it's not a good fixation, you know, you could see where some of these blastic cells are not very big. You know, you would hate to get confused with like a lymphoblastic lymphoma versus a CLL or something like that, because it's like neither of these things are going to have very much cytoplasm, maybe very monotonous. And so you end up try to look at the chromatin carefully and the pattern. But these guys have more of a fine chromatin. But that's why we kind of like for people to do, potentially if they can, let's see if I have it over here, to do a touch preparation on one of these things. And this is something from the Path presenter, which is actually a really nice way to show stuff as well. I don't know if we can see any of these cells. Nice. Touch, yeah, they're kind of a little bit weird looking, but you can tell like that doesn't look like CLL. Those things have a very fine chromatin on them, and it makes it a little bit easier. This maybe not making it a lot easier, a little bit easier to see. Some have like a few little vacuoles in the cytoplasm, kind of a more of a blastic look on these guys.
Do you still do routinely touch preps on all the possible lymphoma cases, or?
Yeah, we do. We have like a protocol where we have what we call like lymphoma protocol, which if they have a very high suspicion, for example, a patient on a transplant or this imaging looks very concerning for lymphoma, they call us down, sort of like a frozen, except for that, doesn't delay the operation. We come down and we make sure that the tissue is, we have the right amount going for flow. There's certain testing that can only be done on frozen that may be useful in the future. And so if we have enough tissue, we save some out for frozen, potentially could be used for research or clinical trials or things like that later. Potentially some stuff could be cultured fresh, for example. Cytogenetics can be very important in certain instances, or if you think it ends up being like a myeloid sarcoma, that might be your only chance to get a true karyotype. So yeah, so we go down there and kind of help triage for flow and formalin and things like that. So yeah, and at that time, definitely helpful to have the touch and print versus just the frozen section, but often we do both. And I think the residents routinely do touch and prints also, even if there's not like an official protocol, we often get touch and prints, which
cool.
I'm very grateful for. I mean, even, yeah, I think they're good for anything. Like, you can pick out other cells, obviously some sort of metastasis or something else is often easier to see on a touch and print, I think. But yeah, these ones, and then for sure, if you see something like this, you can send it for flow, and then it's a slam dunk on the diagnosis. But also with these ALLs, it's very important to have cytogenetics. There's some FISH testing that can be done. Not all the FISH testing is approved for tissue, because usually you have a bone marrow. But with these this is a T lymphoblastic lymphoma, as it turns out. Oftentimes it's T lymphoblastic leukemia lymphoma. Sometimes it's leukemia, but sometimes it's just literally involving the mediastinum, and so that's the only specimen that you end up getting. And so these things could have various cytogenetic abnormalities.
Yeah,
Can I ask you a couple of questions about the morphology, like from the point of view of, so clearly there was a need to look at the touch because it's not always clear cut that this is whatever blastic morphology or not, right?
It can be. I mean, this particular case looks clear, but I think sometimes if it's not, it could. I have seen cases, for example, cutaneous biopsy where there's some crush artifact, it wasn't well fixed, and you end up with a CD4 proliferation. They're like, oh, is this CD4 small medium? Or and then you do a KI and the proliferation rate is like 100%. You're like, oh my gosh, it's a lymphoblastic lymphoma that's involving the skin. So yeah, so it can be hard to see in some cases without the touch.
Pure morphology, am I wrong to say this is very mitotically active, or am I seeing the wrong stuff? Because it looks to me.
Yeah, it's very, well, there's a few that are, there's this very mitotically active as well. Yeah, so these are, I mean, if you're saying this with a KI, it's gonna be 100%, and then there's many mitotic figures. So there's many clues that this is nothing
low grade.
Nothing low grade. Yeah, like this guy, some of it, the scan isn't the best. I don't know, let me see. Yeah, this area is maybe a little better, a little bit thinner. That's the other trick that we like to do. This was an older case, but yeah, also if you get like a 2 micron cut, you can see the chromatin a lot better. You see these mitotic figures. But yeah, so if you end up with like a thick cut, poorly fixed, and you see these small cells, probably maybe no one's going to fall into that trap. But you do still have like a lot of all the mitotic activity and the blastic chromatin. But yeah, you can. So this is another thing you could see in the mediastinum, but obviously this morphology could look very different than a marginal. But your concern in this case, particularly if you maybe only get like a tiny core, you got this big thing and it's just sheets. You stain that for thymic epithelium, you're really not going to see any. This is a lymph node, but if it were, involving the thymus. But what if you just got like a small core and you see kind of these nodules and they're very mature, they're very blastic, they all have TDT. Oh, it could still be the normal thymus or some other process involving the thymus, and you have some residual thymic T cells in there. So basically they can show a range of phenotypes. They're going to be immature, but they may mimic maybe a different subset of immature thymic cells. But the key is to look for ones that basically don't follow the normal maturation pattern or don't show a maturation pattern. And that can be sort of done by staining. It's okay. And certainly you're going to see disruption of the thymic epithelium as well. And they're all going to have, there's certain markers that aren't expressed together. And so if you can say, oh, they're expressing these two markers, which are at different points in a normal T cell maturation, that's wrong. And that's a lymphoma. They'll have a clone, so you can prove that. They may have activation, kind of diffuse activation of the Notch pathway. We have an antibody actually to show that. So there are different ways, but flow cytometry is a little bit better because flow cytometry, you're then looking at all the cells and you can see that they're showing a maturation pattern. And then also, for subsequent tissue, like, that was their, that was their phenotype. And so you can find them again for minimal residual disease analysis. But the centers that do MRD testing are now getting very good, such they can, they can tell, even if they didn't know usually the initial phenotype, that this thing is abnormal and it's falling outside of what, even if there's just a few of them in a discrete population, then it's abnormal. But yeah, these things, your typical problem is a tiny biopsy where you didn't know, whether or not it's, residual thymus.
Yeah. So, one thing I use, even, I don't know if this is correct or not, but just maybe it's practical, is that most thymomas occur in adult people, 30s, 40s, 50s, often women. And most lymphoblastic lymphomas occur in very young people, right? Isn't that correct? So can you use the clinical setting as a...
Yeah, you can certainly use the clinical setting. Like if you have like a 5-year-old show up and you're like, it's a thymoma, it's like, I don't know. That's maybe not, but I think if someone is like, maybe a middle-aged female or something like that, you can't be sure. I think because you can see lymphoblastic lymphoma over a range. Yeah. So I think and the treatment is so different that, you hate to just, I mean, you think statistically, even if you're, pretty positive, it just seems like, it's nice to have
a definitive diagnosis.
The definitive answer. But there have been a lot of papers published on this as well, kind of looking at, what few markers you can do that would help differentiate. And I think in practical purposes, like it very rarely is misdiagnosed because of and people are also, aware of that. And if you get a mediastinal biopsy, they do try to send it for flow and things like that. So, but you often get these immature cells and it's like, or if you only do a very limited panel, you're like, oh no, now we found a whole bunch of immature cells. Now what? Because if you don't have like the maturational pattern of it, it's still a challenge.
That's true.
So,
okay. So we have,
I don't know. It sounds like you're not too worried about those guys, but I mean, obviously this looks like a tumor. If you get something like this, it's just like, it's pretty easy.
Part of the reason I'm not worried about it is because I shunt it off to you guys. You have to worry about it. At least from my point of view, the main question is when to worry about it. Like, we get so many thymomas and almost no lymphoblastic lymphomas that we have to worry about when is the time that you should worry about missing a lymphoblastic. Like that's how I come at it.
No, that's interesting. because we can afford to be like over vigilant because you only send us a few. So if you send us a few, it's like, okay, this one they're worried about. Let's, let's double down. But I think, when you see that effacement of, all of the thymic epithelium, like you don't have any thymic epithelium there, then you worry about it. Or if you're staining with the TDT, it's diffuse, you don't see much thymic epithelium, send it on over. And based on age.
I've got 3 things to help me in that setting. I've got age and clinical setting. Then I have morphology, right? I mean, there's most cases clearly look like lymphoma or clearly look like thymoma. I mean, it's not that hard in most cases. So you're adding clinical setting to morphology, and then you're using pancytokeratin immunohistochemistry. So in most thymomas, it's clear cut that it's epithelial proliferation, and it's not that hard. And in most lymphomas, there's no epithelium there. So if you add those 3 things, the chances that you will miss one or the other becomes so low, that I would think it would be a zebra to miss one of these, as misdiagnose a lymphoma as a thymoma and vice versa. You'd have to
Yeah.
be really unlucky, you'd have to get exceptions on every end.
Yeah, I don't think, I mean, I think we like to talk about potential pitfalls and things. Sometimes it's a little bit like, no one's going to really fall in the pitfall, but yeah. But
Okay, so we got 3 minutes, Eve. You want to show us something else quickly, and we can do a very quick without many questions. Just
okay. All right. Let me see here. This is another TALL that's involving just soft tissue.
Oh, wow.
Yeah. So again, it just looks very monotonous, very little cytoplasm.
I think my thought would be, what kind of small round blue cell tumor is this?
Yeah.
That would be.
But yeah, no, that's pretty good. Like as soon as you say no a TDT or CD3, you're like, all right, now we got it. So those are, yeah. All right, so this is another lymph node that we have here. We have kind of, again, no architecture, but very mixed this time.
Yep.
There's some small lymphocytes, there's big, weird things, there's histiocytes. This is a nice thick section, which is I had from earlier, but you can still see kind of the morphology of the cells. Yeah, I don't know where this one was from. But yeah, here's some little kind of mummified looking guys. And then let's see. But yeah, this is a nice classic case. So here's some here, like this guy, multinucleate.
Yeah.
Kind of prominent nucleoli. The staining here is very dark, unfortunately. So you can't see, they don't look like cherry red nucleoli.
What is something that you would want a trainee to know, Eve? Like some very simple thing about Hodgkin's that you think every trainee should know about that. Besides the fact that the background is sort of polymorphous and the neoplastic cells are big and atypical looking.
Yeah, so I mean, I think if you have somebody presenting with mediastinal mass, and you have this kind of mixed architecture here, and even maybe, in this case, even from the super low power, we can kind of see these big guys jumping out. And this case has particularly striking Reed-Sternberg cells, and particularly large Reed-Sternberg cells. Sometimes, I don't know, maybe you don't necessarily see them on the initial cut, or they're like, I don't know, maybe the morphology isn't that good. Like, just get a CD30. Like, that's my advice. Get a CD30. You have a young person presenting with a mediastinal mass, or elderly person with a mediastinal mass. They could be any age, really. Just go ahead and get that CD30 and make sure that you're not missing. You don't want to confuse yourself, because there could be background. For example, if we did a 30 on our marginal zone, we'd see some scattered kind of immunoblasts around.
Yeah.
But to pick up these larger atypical CD30.
So can I ask you a related question, Eve? So if you had to tell me what would be a super easy, like a Hodgkin's for dummies kind of panel, what would be the easiest, smallest panel for Hodgkin's? And then
unfortunately, our panel doesn't really, we can't get that much better with it, because it has a really defined phenotype. So basically, CD30 is great. You want them to have CD30 that should be strong and membranous and Golgi pattern look to it. But there's a lot of things that can have CD30, and including a lot of T-cell lymphomas, particularly like anaplastic large cell lymphomas. So you want to make sure that you're dealing with, and those can also be in a younger population. So you got to have a PAX5, because they don't have much of a B cell program. These things, they may, in some cases, a subset express CD20, but if they express a lot of CD20, that kind of throws the diagnosis out the window. So the PAX5 plus the CD30 is kind of your minimal panel to be sure you're dealing with something that's large, atypical, and has a B cell program, because your treatment is going to be totally different if it ends up being a T cell lymphoma rather than a B cell lymphoma. The other thing that I like to get is an EBER, to look for EBV association. And you say, oh, well, who really cares, because, it doesn't maybe change the treatment. But you can also get these like Hodgkin-like proliferations that occur in a variety of immunosuppression related settings. And those may be treated differently. For example, if you and so you may have some EBV positive cells, but if you have a lot of EBV in the background, also in small, medium lymphocytes, that implies that this is actually some sort of proliferation that's coming up out of a, immunosuppressed setting. And that could tell you, oh, maybe they had a transplant, you got this in consult, you didn't know that. Or it could tell you maybe they have a background T-cell lymphoma, like maybe there's an angioimmunoblastic T-cell lymphoma going on that's suppressing their immune system. And then we're seeing this EBV positive cells in the setting of that. So I always like to do an EBR to make sure. And if it's an EBV positive Hodgkin, that you can be immune competent young patient with that as well. You don't have to be immune compromised to have EBV positive Hodgkin, but typically it's going to be just in those cells. It's just going to be in the Hodgkin cells.
So that's setting. The dummies panel, right? This very small panel that you do. But now I'll ask you the reverse question. What is the usual panel? Like, what would most people do? How many stains do they? Is it like a full tray of Immunos? How?
I mean, it's actually slimmer than most of our things. CD15. I mean, the cells will also show CD15. That's again not specific. That'll be seen on other, myeloid elements. It can be seen on, tumors across the board. And it's not, and it's often like less than the 30.
Yeah.
It kind of varies. We have different CD15 antibodies you can use. So it's not necessarily as good, but T-cell lymphomas are less likely to have the CD15. Of course, we do a 3 and a 20 because I like to see what's going on in the background. And if you start having really bright CD20 on those cells, then that's, maybe you're dealing with more of a gray zone. Maybe it's a T-cell histiocyte rich. Maybe it's really, if 30 is kind of, maybe you got confused and the 30 is really in the background, and it's kind of on immunoblast, and the 20 is really on your big guys, and they're in this kind of mixed lymphocyte and histiocyte background, then it's more like a T-cell histiocyte rich. Yeah, so it's always good to do those. We typically use cytotoxic markers as well, like granzyme TAA or perforin. Usually granzyme is, I think that one's on our actual panel, but those are typically positive in like an anaplastic large cell lymphoma. Nice. And so that helps you kind of make sure that you're just like, okay, this is really not trying to be a T-cell. But various Hodgkin lymphomas can express different amounts of T-cell markers as well. So it's not a slam dunk, but if you start having like a whole bunch of T-cell markers, you're like, okay, that's a little bit of a no-no for a Hodgkin, unless it really fits everything else. And then ALK. Usually people do an ALK.
Sorry. Does anyone ever diagnose Hodgkin's without Immunos nowadays, Eve? Does anyone?
I think they used to, but no. I don't think so. But sometimes you really know it is. Like you see it in Frozen and you get the beautiful Reed Sternberg, or also even in Touch Prep, like, look at it, I have a bunch of EOs. I've got my, these Reed Sternberg cells. I've got it. So I think you can definitely favor it. But given the possibility that, you could have a T-cell lymphoma in a mixed background, or T-cell histiocyte rich, or any sort of EBV driven process can have Hodgkin-like cells. CLL, you can have Reed Sternberg cells kind of popping up in the background of CLL, or you can have full transformation to like a Hodgkin-like process too. So it's like there could always be something in the background that's changing it. So I think we're moving too much maybe towards stains in heme path, but yeah.
That's the modern world. Moving too much towards stains and everything, right? I mean, it's not. Matt, so we'll let Eve go.
Yes.
Because she has to leave. But anything else you would like to ask her before we thank her?
I think this has been great. Thank you so much for joining us. I've learned a ton, and it was very educational. Thank you so much.
Oh, it's really fun talking to you both. I really appreciate being here. This has been really fun.
Thank you, Eve, for giving us a chunk of your time on a Sunday morning.
Yeah.
Oh, no, absolutely.
Really appreciate it.
Thank you.
Okay, take care. Bye.
Bye. Bye.